Hello everybody, so this is your coronavirus update for today. So it's a little confusing here today because I'm on hold from, excuse me, from Expedia for trying to cancel something and it's impossible to get on them. I was on hold for an hour and then I finally spoke to somebody, then the phone cut off and they tried to get back to me and couldn't. I think we're overusing these cell towers now because everybody's so scared and, trying to contact people. But anyway, let's go over what I have for today. I added a couple extra things here that we can look at. Excuse me. Tough having allergies during this time too. All right, so this is what we have in terms of Italy right now. There's prevalence is 34 people per every 100,000. It's a change of about 5 individuals since yesterday, an increase. So testing is happening, and I guess people are being detected. So that's what I mean. This is pretty simple, right there. Still the worst in the whole world based on all the data we have available. Let's see. Norway's pretty bad though, 23 per 100,000. Yeah, so that's getting pretty high up there for a small country. In terms of the United States, we're at 1.12 per 100,000. That's an increase in about a quarter of a person over the past 24 hours. And again, just to be clear, the data I'm using come from John Hopkins here, from the Coronavirus Resource Center. So just to keep you posted, that's where you can get these data. And of course, the estimates of population size are all estimates because it's never perfect. So I'm looking in terms of Canada. I think I had some larger numbers yesterday. I don't know if I entered the data wrong or was there a data entry error yesterday because it was like 6 something, but it's really 3. So I'm not going to look at this difference right here because this is meaningless because this was based on a larger value. But right now in Canada we're about less than a person per 100,000. So let's see. In terms of the United States, where we're at now, the largest prevalence is in New York, which is about 4 people per 100,000. Well, actually, no, sorry. In Washington, still it's 9 people per 100,000, followed by New York. And I still need some new data on Oslo, so I can't really report on these. In terms of increases, the biggest increase was in Washington, which was over 1.5 person per 100,000. I still have this difference between France and I was doing this difference between France and Italy because they're comparably sized countries, and so Italy has way more cases per 100,000 than. So this is a difference in the prevalence, way more cases per 100,000 than France. Italy has more than France now. So things are still doing what they're doing. So let's look at some other information that might be useful. So I was trying to find out what the prevalence of, excuse me, not the prevalence, the sensitivity and specificity of our tests that we're using. So the best thing I could find, and most sites do not provide you with sensitivity and specificity. So sensitivity is the probability of testing positive given you're disease positive. So imagine you take a test, you have the disease, and the test should indicate that you have the disease. So that's called sensitivity. Specificity is the probability of testing negative given you don't have the disease. So you'd like high sensitivity and high specificity, because imagine if you tell somebody who has the disease that they don't have the disease, they'll go about infecting others. If you tell somebody that they have the disease when they don't have the disease, that could cause some serious psychological harm to that individual, as also would be like a false negative, like you tell them they don't have the disease. Oh, well, we already said that one. They don't have the disease when they do, actually, then that's not good either. So we want to make sure that we got everything as high as possible. So right now, the best sensitivity, this was done in a study that was done, published in Journal of Medical Virology by Zhufeng Wang. And here's the information you need if you'd like to look it up. And actually, I think I have that study up right here. This is its you can get access to the whole thing if you're interested. Thankfully, it's free. Sometimes people actually do publish things for free. So there's your information. But let's go back to this calculation here. So this is what's called conditional probability, and right now the sensitivity is like 89% or 0.8866, right? So it's not extremely high, but high enough, I guess, for right now. Specificity is 0.9063. I also calculated what's called a positive predictive value. That's a probability that one has the disease given one tests positive. So if you test positive, you think, okay, well, I must have the disease. Well, if you look at this value here, it's very small. It's 0.000106. In public health, we generally try to not do a lot of screening, and this is what's being done now. This is called secondary prevention. Screening, we want to know if somebody already has the disease, can we stop it? Well, not necessarily stop it, can we detect it so we can take appropriate measures with that individual? That's what all screenings are done, whether it's breast cancer screening, colon cancer screening, or screening for the novel coronavirus. Well, that's very low, and the reason it's low is because of the the prevalence. If you look at this is, I don't know if you're interested in formulas. This is called Bayes' theorem or Bayes' formula. So you have, in this case, it's sensitivity times the prevalence divided by, again, what's the total probability of testing positive. So you could test positive and have the disease, which is sensitivity, plus being a false positive, right, times 1 minus the prevalence. So that's what the formula is here. So the issue is that just because you test positive doesn't mean you have the disease. But generally, we wouldn't want to screen for low prevalence diseases like this one. But anyways, that's your latest information for today. And let's keep on trucking, right? All right.